Medurstand Understanding Medicine.
I'm Professor Aziz Rehman, and today we're going to talk about a very tricky situation called hyponatremia. It's a fairly common condition, and in some cases, it may be very simple to diagnose and simple to treat, and maybe we actually already suspect it and we confirm it and we treat it. But sometimes it can actually pose a real challenge to find out the cause and to treat it. So this is actually first of the two parts, and in this one I would just discuss the homeostasis of sodium, how sodium is regulated in the body, and its etiology and diagnosis. First of all, what is the importance of sodium? It is an extremely important electrolyte. And if I say that without sodium, no body cell can function properly, I wouldn't be wrong. So whether it is your neuron or your renal tubular cells or your myocardial cells, every cell of the body needs proper amount of sodium. And we need to consume proper amount of sodium in the diet also. And what is the definition of hyponatremia? Normally, our sodium is present in the extracellular compartment in the concentration of 135 to 145 milliequivalents. And if it is less than that, and you have confirmed that this is actually low sodium, not because of any laboratory error, so that is called hyponatremia. And this is how it is distributed, and this is a schematic diagram, and this cube represents intracellular compartment because intracellular compartment is the biggest. This cube has got greatest volume. Then we have interstitial compartment, and then we have vascular compartment. And you can see these differentiating or these partitions, and this has got very small fenestrations, so only solutes can pass, like sodium and chloride and potassium can pass. They are also regulated by sodium potassium ATPase, but this membrane is permeable. This cell membrane is permeable to electrolytes. But this membrane, the vascular membrane, is permeable to not only electrolytes, but it would allow macromolecules also passing through this. So as far as sodium and chlorides are concerned, these two compartments are actually one, as shown in this picture. So I think for the purpose of sodium and potassium and other electrolyte discussion, we have only two compartments, intracellular and the extracellular compartment. Although this membrane is permeable, so normally there would be same concentration. If there are two compartments separated by a permeable membrane, then the concentration of sodium should be same in both the compartment. But in our body, there is sodium potassium ATPase, and this actually keeps our intracellular sodium in a very low concentration, whereas it keeps the extracellular compartment sodium in a high concentration. Opposite is true with potassium, but in this lecture we are discussing sodium. So when we say hyponatremia, we actually referring to the extracellular compartment sodium. We take it from blood, but this would represent the interstitial sodium also, because interstitial and the vascular compartment is the same as far as sodium is concerned. Normally the concentration is from 135 to 145 milliequivalents per liter. So if it is less than that, that would obviously be called hyponatremia. If it is more than that, that is called hypernatremia. How is sodium regulated? Sodium homeostasis. So this is the sodium, and there are actually multiple mechanisms to control our serum sodium. First of all, antidiuretic hormone. Now, as you can judge from the name, antidiuretic hormone is the hormone which would prevent diuresis, which would prevent too much diuresis. Now, this is the hormone which is actually produced by the hypothalamus. It is further regulated by osmoreceptors and the thirst mechanism. This antidiuretic hormone is produced by the hypothalamus and is brought down to the posterior pituitary, where it is stored and is released as and when it is required in a normal physiological state. But in some situation, too much ADH may be released, and we will discuss about that. And in some condition, there may be deficiency of antidiuretic hormone that would result in excessive diuresis. Now, what does this hormone do? It acts on the distal tubules of the nephron and will make it permeable to water. You know, kidney interstitium is highly tonic. It has got hypertonicity. It will suck fluid due to osmosis. So if there is no antidiuretic hormone, and water will be excreted, so antidiuretic hormone will make the tubules cells permeable, so that fluid is sucked back into the interstitium. So that will prevent too much loss of water and salt into the urine. And the second mechanism, thirst mechanism, in a normal conscious person, and the thirst mechanism is very, very efficient. And if you lose water or salt because of say excessive sweating, and you will feel thirsty and you will feel like drinking water. And I think this thirst mechanism is very, very efficient, and it can very correctly judge how much your body's how much sodium your body has. So accordingly, if your body is deficient in salt and water, then you will feel thirsty. By the way, salt and water go hand in hand. Both are regulated the same way. And then we have this renin-angiotensin-aldosterone system. You know, this is the system which is initiated by the kidneys. There is renin is produced by the kidneys in response to hypovolemic state, dehydration, hypotension, and this would activate angiotensin 1 conversion into angiotensin 2, and then angiotensin 2 would cause vasoconstriction, so that will help to raise blood pressure. It will also stimulate production of aldosterone from the adrenal cortex, and that will retain sodium and water, so normalizing sodium and water. And then finally, we have osmoreceptor in the hypothalamus. This osmoreceptor and thirst mechanism, they work together. All these four mechanisms, they coordinate with each other in a way that in the normal circumstances, if you have access to food and access to water and salt, there is extremely rare chance that you would develop hyponatremia or hypernatremia. So if there is hyponatremia, there has to be a cause. Either your access to sodium and water is lost, or you're losing too much, or there is some problem with one of these regulatory mechanisms. So the symptoms, let's talk about the clinical presentation. And in mild hyponatremia, and now of course there are some clinical features, and on those clinical situations we already suspect hyponatremia, but I'm talking about this laboratory abnormality. If you have mild hyponatremia, like sodium is less than 135 but more than 125, you may not have any symptom at all. Symptom which can be attributed to hyponatremia. There may not be any symptom at all. If you have mild hyponatremia, like sodium ranging between 120 and 125, then there may be mild vague symptom. Again, on the basis of these symptoms, it may not be possible to make a diagnosis of hyponatremia, because the symptoms are too vague, and vague symptoms could come from many other conditions. But if there is severe hyponatremia defined as serum sodium less than 120, especially if it is less than 110, that would be very, very critical hyponatremia. Then of course patient would have symptoms. Patient would have altered state of consciousness in the form of drowsiness, confusion, delirium, or patient may actually have seizures. Now this of course can also occur in other condition, in meningitis and encephalitis, other condition, but severe hyponatremia is also one of the causes. So I think diagnosis of hyponatremia on the basis of clinical features is not easy unless you have certain circumstances where hyponatremia was suspected. Like for example, somebody presented with severe diarrhea, then you would be already suspecting hyponatremia. You would do the test, so the interpretation will be easy. So to assess the exact cause, you need to understand the symptoms of the background disease and also the symptoms of concurrent disease. In this case, concurrent disease like gastroenteritis and background disease, the people who may not have any concurrent disease, but because of their background disease, sometimes very mysterious diseases like carcinoma bronchus, there may be hyponatremia. That will be discussed actually in the next lecture. So first of all, the clinical assessment. The clinical assessment, I think very important, you assess the hypovolemic hyponatremia, and this will occur when there is a history of fluid loss. Very simple, the commonest is gastroenteritis, especially in children. If there is diarrhea, or there is vomiting, and especially if they're both, because just diarrhea may not cause severe hyponatremia because patient would be taking water and salt and that may be correcting the hyponatremia. But if there is diarrhea as well as vomiting, and I think there is maximum chances of developing hyponatremia. And clinically, you can assess the signs of dehydration, mucous membranes like tongue and mucosae and eye and maybe dry, and skin turgor may be reduced, and there may be low blood pressure, especially when you take blood pressure in the standing position, and there may be tachycardia. Resting tachycardia in the setting of dehydration would indicate severe dehydration. So that would confirm hypovolemia. If there is hyponatremia in the setting of hypovolemia, then the differential diagnosis is very simple. But then there could be hypervolemic hyponatremia, and if you take history, patient may be already a case of a kidney disease, a chronic kidney disease, kidney failure or nephrotic syndrome, or patient may have liver disease like chronic liver disease or cirrhosis, or patient may have heart disease, heart failure. In these conditions, patient has got hypervolemic hyponatremia. The volume of body is increased, but sodium is reduced. Now, the clinical signs in these conditions would be presence of edema, which is mostly dependent, and also pitting, and there may be ascites, there may be pulmonary crackles indicating pulmonary edema, there may be reduced air entry on the lung bases indicating pleural effusions, or there may be hypertension. So all these conditions, they would suggest hypervolemic hyponatremia. I think these two are relatively simple conditions, but the most difficult thing is that this one, euvolemic hyponatremia. Although we use the word euvolemic indicating that there are no clinical signs of hypervolemia, but actually these patients are slightly hypervolemic. Not in the sense that you can clinically pick it up, but these patients, they have actually retained some water, and in these patients there would be no obvious cause, because cause is not related directly to the fluid balance. It is related to some other condition which will be discussed in the next lecture. And clinical signs, there may not be any signs related to hyponatremia or hypovolemia. Okay, so this is actually a difficult condition. You should look for some underlying condition, or patient may be taking some medication which is causing this. So after clinical assessment, we'll go for laboratory assessment. First of all, of course, we receive the report of serum electrolytes. It's a part of serum electrolytes. We get serum sodium, and you notice that the sodium is below 135. So the suspicion of hyponatremia is raised. This could be true hyponatremia or could be pseudo hyponatremia. Now, I think another laboratory test which is very useful is urinary sodium. Because if there is true hyponatremia, if body is truly deficient in sodium, then kidneys must be trying to preserve every single molecule of sodium passing to the nephrons. So urine must be very low in sodium. or at least not high in sodium. But in some other condition, urine sodium may be normal or high. If somebody is severely hyponatremic and urinary sodium is still normal, so that would be called falsely normal. Because in actual hyponatremia, you expect urinary sodium to be low. Then serum osmolality is another test, because serum osmolality is mostly determined by serum sodium. But in some cases, there may be accumulation of some other substances in the body. They could change your serum sodium, but there may not be actual hyponatremia. So if there is reduction in serum osmolality, that would indicate that the hyponatremia is real. Then urinary osmolality, this would actually confirm the value of urinary sodium. You would draw the same inference as you would draw from the urinary sodium. So these are the 4 laboratory tests which may be required to go into the details of hyponatremia. Now let's go the scheme. First of all, you get the report of hyponatremia, you correlate with clinical condition. If patient is having reason to have dehydration, or there is an already known disease which explains hyponatremia, then you just take it on the face value. But if hyponatremia was unexpected, I think my approach is to reconfirm, because it may be laboratory abnormality or it may be what is called pseudo hyponatremia. So what is pseudo hyponatremia? If there is accumulation of some solute in the body other than sodium. As I told you, normally it is the sodium which determines our serum osmolality, but in some cases there may be other substances. For example, if there is a lot of protein in cases of hyperproteinemia like multiple myeloma, or if there is hyperlipidemia, massive hypertriglyceridemia, these two things will actually take some space in the fluid component of our plasma. So when we take sample to measure sodium, some of this sample may not be actually the actual plasma. It may be, the space may be taken up by the protein and the lipids. So you are measuring sodium in that sample, but the sample is actually less than it. The whole sample is not serum. So you are measuring sodium which looks like low, but if you measure serum osmolality, that will be normal. Okay, so this is how to differentiate between pseudo and true hyponatremia. In true hyponatremia, serum osmolality will be low. And then true hyponatremia, if true hyponatremia is confirmed, then you have to actually go further and you have to assess the body volume status. If there are 3 situations. One is hypovolemic states, then the cause of hyponatremia is easy. The other is hypervolemic state, then it is again relatively easy. And the third one is euvolemic state. So that is actually more tricky situation. Now, on the basis of this, we determine if there is depletional hyponatremia or dilutional hyponatremia. What is meant by depletional? That means body is actually depleted of sodium. This occurs when there is loss of sodium and water, but there is no replacement of sodium and water. So the total body sodium is actually low. So serum sodium is low, serum osmolality is low, and total body sodium is low. There is no way to measure total body sodium, but we can differentiate. We can determine this condition on the basis of history. Dilutional hyponatremia is a condition, and the other name is syndrome of inappropriate ADH secretion. There are actually other causes also, but most important is syndrome of inappropriate ADH secretion. In this condition, actual total body sodium is not low, but it is the retention of water and retention on the water in a way that you can't judge on the clinical examination. You don't have signs of volume overload, but extracellular compartment is expanded. And this is because your ADH is inappropriately high. This occurs in many diseases, and this topic will be taken up in the next lecture. And then urinary sodium should be done. Urinary sodium will tell us if there is true hyponatremia, this depletion hyponatremia. As I said in my earlier slide, if there is actual sodium deficiency resulting in hyponatremia, then and the kidneys are functioning normal, and kidneys will be trying to preserve sodium, and urinary sodium will be low. Since urinary sodium is subject to your overall status of hydration and the time of the day, for example, in the morning your urine is concentrated, in the afternoon urine may not be concentrated. So if you measure urinary sodium and the creatinine, that will correct for the urinary concentration, and that will give you a better view about the urinary osmolality. So this is how we go, and I think it might look easy, but in some situation, differential diagnosis of hyponatremia is very difficult. Serum osmolality needs to be measured when you suspect, when you have to differentiate between true hyponatremia and pseudo hyponatremia. Now, in a true hyponatremia, serum osmolality will be low, and in this situation, there is hypertonic hyponatremia. Patient has got hyponatremia, but actually serum osmolality is high. This is because there is something else which is increasing osmolality, but that is not sodium. And for example, in severe hyperglycemic state, or somebody who has been given mannitol, which is a type of sugar, or somebody who has been given IV contrast for some study, and if you, during that state, since serum osmolality will be high, osmoreceptor will judge it, ADH will judge it, and other homeostatic mechanism will judge it, and because of osmotic effect, some of the fluid from within the cell will be sucked in outside the cells into the extracellular compartment. So extracellular compartment fluid is increased temporarily. So that has caused hyponatremia, but because of the presence of these solutes, the osmolality is high. And then there may be normal osmolality in case of hyponatremia, and this is pseudo hyponatremia when there is hyperlipidemia and hypoproteinemia. These are the situation where these two substances, they actually take up some space. So what you're measuring, you have taken certain amount of sample when you take laboratory tests, but that whole sample was not serum. When you make calculation, you actually underestimate sodium, whereas sodium was not low. So this is pseudo hyponatremia. So if you have confirmed true hyponatremia, then you have to differentiate between depletional and dilutional. This is a situation where there is actual sodium deficiency in the body represented by hyponatremia. This is a situation where there is hyponatremia but total body sodium is normal. It is the excess of water because of excess of ADH which is causing dilutional hyponatremia. So then you go one step further and you differentiate between three conditions: hypovolemic hyponatremia, hypervolemic hyponatremia, and euvolemic hyponatremia. In hypovolemic hyponatremia, you actually have both sodium and water loss, but sodium loss is more than water. And it is usually caused by diarrhea, vomiting, bleeding, and burns. And there is use of diuretics, and there may be some renal sodium losing nephropathy. Okay, so these are the causes when you have hypovolemia or hypovolemic hyponatremia. In all these situations, there is loss of sodium and water, but sodium loss is more than water. Then let's talk about this condition, hypervolemic hyponatremia. and this sodium and water both are retained, both are in excess, but water is more than the sodium, just opposite of this. So as a result, because water is more as compared to sodium, there would be hyponatremia, and this can be seen in heart failure, cirrhosis, nephrotic syndrome, and this condition is usually complicated because these patients may be taking diuretics. They are also natriuretic substances, so they may be losing sodium more than the water. So this is how you differentiate between different conditions. Euvolumic, I think this in my opinion is the most difficult, since it is a very difficult one, and out of these four conditions, most important is syndrome of inappropriate ADH secretion. But in adrenal insufficiency and in primary polydipsia, there may be hyponatremia also. We will discuss this condition in the next lecture. With that, I'd like to thank you for your patient listening, and I really look forward to see you in my next presentation. Please do watch the next video also to complete the module. Thank you.